సఫారీ కూడా తీసేనా సార్ యూట్యూబ్? జూమ్ ఓపెన్ చేస్తే ఇదే వస్తుంది సార్. ప్లే చేసి డన్ నొక్కినా సార్.
Namaste, everyone. Just someone respond if I'm audible. Devika Ahalya, are you here? Kindly respond if my audio is audible. And please switch on your video as well.
Good evening, sir.
Yes, audible, right? Okay.
Yes, sir, I can hear you.
Okay. So, welcome back to the third session of continuous education from NMO. So today we are having OBGYN case presentation, and the case presentation is from Medco Ahalya. She's from NRI Medical College, and the consultant is Dr. P. Supriya. She's assistant professor at RMC GGH Kakinada. So before we proceed for the session, we'll start with Omkaram and NMO mantra, and then proceed for the session. Please, all of you sit straight and repeat after me the NMO mantra. Natvaham kamaye rajyam, न स्वर्गम न पुनर्भवम, कामये दुःख तप्तानां प्राणिनाम आर्तिनाशनम. So, Ahalya, are you ready for your presentation? Anyone else who can respond? I think Ahalya internet is not working well. Dhanush.
Yes, sir. Sorry, sir.
Okay. You are ready?
Yes, sir.
Okay, Dr. Supriya will take over.
Good evening, ma'am.
Good evening, everyone. Am I audible?
Yes.
Myself, I'm Dr. Supriya. I'm assistant professor in the Rangarai Medical College, GGH, Kakinada. And today our presentation is by Dr. Devika, right?
Yes, ma'am.
So it
Yes,
is
ma'am.
a
Devika.
in antenatal care. Am I audible?
Yes, ma'am. We can
Devika,
hear you,
you
ma'am.
can proceed with your session.
Yes. Ma'am, can you hear me, ma'am?
Yeah, not that clear, Devika. There is a bit of disturbance in your voice.
Madam, can you hear me, ma'am?
It's okay now. Yeah.
Yes, ma'am. Good evening, everybody. I'm Devika Ahalya, second year student in NRI Medical College, Nikakani. Today, I'll be presenting to you an obstetric case presentation. My topic is scheduled antenatal checkup. So, the contents of today's presentation: general
Devika, your voice is not
systemic
audible.
examination,
Devika. There is a disturbance.
obstetric examination, and diagnosis of.
You're not audible, Devika.
So coming to the case history, first I'll read the patient profile. Is it still there, ma'am? Logged into the Wi-Fi again, ma'am.
There is a kind of disturbance. It's not clear, Devika. You
Hello.
can be better.
Ma'am? Ma'am, now can you hear me, ma'am?
Yeah, proceed.
Yes, ma'am. So she is Mrs. XL of age 24 years. She works as a data entry operator in Mangalgiri. Her husband is Mr. SSR, who works in the IT department in Mangalgiri. They belong to the upper middle class according to modified Kuppuswamy scale. Her obstetric index is G1P1. Her last menstrual period was on 27th of July 2024,
Sorry,
and her estimated delivery date. Yes, ma'am.
So is she primary?
Yes, ma'am. She is a primary gravid.
So the score should be G1, P0, L0, A0, D0. It's not P1.
Ma'am, yes, ma'am. I should exclude the present pregnancy. Yes.
Yeah. So I'll ask you now.
Her
So
estimated
now,
delivery date. Yes, ma'am.
Yeah. Continue.
Her estimated delivery date is on the 3rd of May 2025, according to Negli's formula.
Devika, your voice is a bit. It's
30
not.
weeks and 6 days.
Your voice is a bit disturbed. Like it's not clear, Devika.
My Wi-Fi is a little slow, ma'am.
Okay.
Okay. Is it okay now, ma'am?
Yeah.
Okay. Should I continue, ma'am?
Okay, yeah, continue.
Yes, ma'am. The patient is booked and immunized. Her blood group is B positive.
Don't change the slide, okay? Don't change. So now you have asked her age.
Yes, ma'am.
It's 24. Why do you want to note the age of the patient? How is it relevant to your history?
Age is important because there are chances of teenage pregnancies and advanced maternal age pregnancies, ma'am.
Okay.
Both of them have their risks and complications.
So they are categorized as high risk.
High risk pregnancies, yes.
What are the complications you expect with a teenage pregnancy?
Okay. In a teenage pregnancy, for the mother, antenatally, we can expect anemia, malnutrition.
Yeah.
We can expect preeclampsia, ma'am.
Yeah.
During delivery, we can expect cephalopelvic disproportion.
Okay.
There will be difficulties during labor, and we will have to go for cesarean section, ma'am.
Okay. So what about
post-delivery? After birth of the baby, the mother can experience mental issues.
Yeah, emotional upset.
Hello.
Yeah. What are the complications after delivery you expect?
Hello. Yes, ma'am. Emotional aspect is also the emotional. Yes, ma'am. Emotionally, the mother can be affected, and there is a problem with lactation also.
Yeah, there will be a difficulty in lactation. So what about the elderly? What is the cutoff age where you'll call it as an elderly pregnancy?
Hello, ma'am.
Yeah, continue. Am I audible? Hello. Am I audible, Devika? Hello.
చెప్పండి మేడం.
సార్ ఇది కొంచెం రావట్లేదు. హలో. నా వాయిస్ వినిపించట్లేదు.
హలో అహల్య.
మేడం మీ సైడ్ నుంచి కరెక్ట్ ఉంది, అహల్య సైడ్ నుంచే కొద్దిగా డిస్టర్బెన్స్.
ఓకే.
స్టేబుల్ ఇంటర్నెట్ ఉందా అమ్మా అహల్య? అహల్య, స్టేబుల్ ఇంటర్నెట్ ఉందా అమ్మా మీ దగ్గర?
I will call her.
ఉంది సార్. ఎస్ సార్, మార్చేశారు ఇప్పుడు. సారీ సార్, ఉంది సార్, మార్చేశారు ఇప్పుడే. హలో.
Present చేయండి.
ఎస్ సార్. Sorry, ma'am. I have a Wi-Fi problem.
So what is the cutoff age for to call it as like elderly pregnancy?
Any age above 21 years.
Ahalya, your net is very problematic. You're not audible.
Means it is a normal pregnancy, cutoff age for pregnancy.
So what do you call as elderly? When do you?
Now is it
Yeah,
okay?
yeah.
Ma'am? Elderly pregnancy is an advanced maternal age pregnancy of above 35 years of age.
So what are the problems you anticipate in that age?
Okay. In advanced maternal age, again during delivery there is a less activity of the uterus is there, which makes it difficult for.
What are the antepartum complications you anticipate during pregnancy?
Again, we have to opt for cesarean delivery. Okay. Antepartum complications are preeclampsia. Yes, ma'am. Preeclampsia can be seen.
Okay.
Mellitus is also seen, ma'am. Is also possible.
Gestational diabetes is common.
Yes, ma'am.
Yeah, and also she's advanced age, so there is every chance for aneuploidies and
chromosomal. Yes, ma'am. Chromosomal abnormalities. Yes, ma'am.
Abortions are also very common.
Yes,
right. And also there is every chance of IUGR. If she landed up in preeclampsia, there is every chance of IUGR.
Yes.
And what are the complications during labor you anticipate in a elderly woman?
Reduced activity of the uterus and present.
What is the terminology called?
I can't remember.
It is uterine inertia.
Yes, uterine inertia.
Yeah. And also there will be incoordinate uterine action, means the uterus will not act properly in a coordinated manner. Right? Yes, and also there is every chance of cesarean delivery because of this.
Yes.
And in the postpartum, what is the complication you expect?
Again, mental health issues to the mother and lactational.
And also lactation failures are also very common. So that's
yes.
why the age, noting the age of the patient is really important to categorize the pregnancy, whether it is a normal pregnancy or it is a high-risk pregnancy, right? If it is
yes,
teenage, if it is less than 20 years or if it is more than 35 years, write it as high risk. That's it, right? And you should be more cautious with her.
Yes.
And you have mentioned about the occupation of the patient. So how is it relevant? Occupation, how is it relevant?
Many occupational
Your net is very problematic. It's not audible here. You're not audible, Ahalya. Ahalya, you're not audible.
Fetus, ma'am.
You're not audible.
For example, this particular mother here works in the this mother works,
suppose she's an IT professional, then
data entry operator in the radiology department.
Yeah, there is every chance of radiation hazard to the patient. Excuse me, am I audible to the other persons in the group?
ఇంకా మీ సైడ్ నుంచి వాయిస్ క్లియర్ లేదు, కొద్దిగా దాన్ని క్లియర్ చేసుకుంటారు, కొద్దిగా ఏదన్నా మంచి సిగ్నల్ వచ్చే ప్లేస్ కి
వెళ్తారా? Can you hear me now, ma'am? I unmuted myself. Hello.
వినిపిస్తుంది అదిగా.
So how is the occupation important, Devika? You have been telling, but I couldn't hear you anything. Like the signal is very bad.
Madam, just Devika got logged out. She's joining again.
Okay. Am I audible to the other persons, right? Am I clear?
Yes, ma'am. Yes, ma'am. You're clear.
Yeah.
Devika, just mute other participant. Just mute check.
Yes, ma'am.
Devika, mute.
Ma'am, can you see, ma'am?
I'm able to see you, but your voice is like, it's not continuous. It's like breaking.
Yes, we can see Devika.
Yes, because she works in the IT. Hello.
Devika, madam, లోపల ఉంటున్నారు. Madam is on. Devika, can you hear? Madam is online.
Yes.
Devika, we are unable to hear you.
The signal is so bad that we are not able to hear you, Devika.
Devika, can you
Hear me now, sir? Ma'am, you were asking about the occupational hazards in IT department.
Yeah.
Okay. Because she works in the IT department, she'll be sitting for too long, ma'am.
Okay.
So this will cause obesity problems
Okay.
and edema problems can be seen, ma'am.
Okay.
Preeclampsia is also
stressful
possible.
job, no?
better?
There's a good chance she may develop preeclampsia. If it's really
Yes,
a
ma'am.
stressful job, she may develop preeclampsia or diabetes, right? So that is
Yes,
the
ma'am.
relation of occupation. And
Yes,
for
ma'am.
suppose if she's like a daily laborer or doing some heavy hard work, she's more prone for preterm deliveries, anemias, infections, whatnot, right?
Yes.
So
Yes, ma'am.
coming to the socioeconomic status, this is also important, right? So
Yes, ma'am.
certain diseases are more common in low socioeconomic strata. What are those?
Anemia can be seen, malnutrition can be seen, ma'am.
Yeah.
Infectious diseases are also
Chances of tuberculosis,
ma'am.
because India is endemic to TB. Tuberculosis
Yes,
is
ma'am.
very common. Sexually transmitted diseases are also very common, right?
Yes, ma'am.
And coming to
Yes.
the high socioeconomic strata, what are the diseases which are common?
Again, we can see gestational diabetes mellitus and we can see obesity, ma'am.
Preeclampsia, obesity. These are all very common in that socioeconomic.
Yes, ma'am.
Yeah. So now you have written the obstetric formula as G1P1, which is
P0. Yes,
right.
ma'am.
So what is, I want to ask you, what is gravida?
Okay. Gravida refers to gravida means a pregnant mother who has conceived irrespective of what the outcome is. If she is pregnant, it is gravida, ma'am.
So that should include the present pregnancy also.
Including present pregnancy, yes,
right?
ma'am.
Irrespective of the outcome.
Outcome.
Right? It is the total number of pregnancies, including the present pregnancy.
Present pregnancy.
Para.
Para means the number of viable pregnancies, that is the number of pregnancies that have crossed 28 weeks of gestation, excluding the present pregnancy, ma'am.
So now your formula should be G1, P0,
P0.
L0, D0.
Yes,
so what is the period of viability?
Okay. Period of viability is the period after which the baby can survive out of the mother's uterus, ma'am.
Yeah. So previously it used to be 28 weeks.
Yes. Oh,
but
yes,
now, because of the advanced NICU care, the cutoff has now become 24 weeks only.
Yes.
And also the birth weight of the baby, previously it used to be 1 kg, 1000 grams. But now it is only 500 grams. Right? So the cutoff of viability has been changed in years. It is not the age old 28 weeks and 1 kilogram. That was not the cutoff. Right?
Yes.
So now you have calculated her, you have taken her LMP and you have calculated her DDD. So what is that formula called?
The formula is called Naegeli's formula, ma'am,
So how
in
will you
which we have to add
calculate?
9 months plus 7 days to the last menstrual period if the mother has 28-day regular cycles
Okay.
without any history of using contraceptive methods.
So why
ma'am.
did you ask for the history of contraceptive pill usage?
Because of contraceptive pill usage, there's a chance that the cycles may get irregular. ma'am.
Not exactly. Because once she uses contraceptive pills and once she stops that pill, the ovulation after that stoppage, the next cycle, the ovulation can be delayed. Right? It need not be exactly after 2 weeks. Right? From her last LMP. The
Yes.
ovulation can get delayed. Right? That's why
Yes,
if she has used contraceptive pills, we can't determine her EDD
Yes.
basing on her
Yes.
LMP because there will be a delay in the ovulation. It's not about the cycles being irregular. It is because of the delay in ovulation.
Ovulation.
Right? And provided this Naegeli's formula is applicable only when the mother is having regular cycles. Right? So what is the cutoff below which you call it as a regular cycle? Till how many days?
25 to 35 days of regular cycles are regular.
Not exactly. It is 45 days.
Okay.
Right? So if it is below 45 days, right? For suppose she's having cycles every 40 days. Then you can add those extra days.
Okay.
This
Yes,
Naegeli's
ma'am.
formula
So,
is for regular 28 days cycle. So
Yes, ma'am.
the extra days you can add to her dates, not the 7, not it is plus 7. It is the plus the number of days, extra days.
Okay.
Right? If
Yes,
she is having cycles before 45 days. But if the cycles are more than 45 days, then you should not rely on this formula. This is
Naegeli's
not
formula.
valid. Right? For suppose she's having cycles below 28 days, what will you do?
We have to take an average of her three cycles
No need. So you can just subtract the number of days.
from 7 days. Okay.
Yeah, that is it. So if it is above 28, you add them. Below 28,
Below 20,
subtract.
subtract.
But if it is above 45, don't consider this EDD,
Naegeli's formula.
Naegeli's formula, right? So period of gestation. Now you have told that the patient is booked. So what do you mean by
Yes.
a booked case?
A booked case is when the patient has the right number of antenatal visits, ma'am. Checkups
How
are
many visits?
okay. Ideally, according to WHO criteria, there has to be 13 visits during her antenatal period, ma'am.
Okay.
So
What
once
is
when
the
she has
frequency
conceived,
of the visits?
ma'am.
What is the frequency of those 13
Yes,
visits?
ma'am. So once when she has conceived, so once in the first trimester, in the second trimester, once every 2 weeks, ma'am.
Not exactly.
Sorry, four visits in the second trimester.
I'll tell you. You're a bit confused. So I'll tell you. So it is like every month. If it is in the first trimester, how can you divide the pregnancy according to trimester in weeks? Can you tell me?
Yes, ma'am. 3 trimesters. The first trimester is from conception to 12 completed weeks of gestation.
Okay.
The second trimester is 13th week of gestation to 28 completed weeks of gestation.
Okay.
The third trimester is 29 weeks of gestation to delivery.
Yeah. So this is how you divide the total pregnancy into 3 trimesters. Right? So what are the ideal visits? Means, so till 28 weeks, she should have every monthly checkups. Means checkups for every 4 weeks. Right? From 28 weeks till 36 weeks, she should have visits every 15 days. And after 36 weeks till 40 weeks, it should be every weekly checkup.
Yes.
Right? So this is the ideal checkups. It should be 13 checkups. Those are the ideal checkups. But for a case to be booked, you need not have ideal checkups. Right? Only 3 checkups are enough to call it as a booked case. Right? So when should those 3 checkups happen? One, in the first or second trimester. And minimum 2 visits are compulsory in the third trimester. Right? Total 3 checkups, minimum checkups are required to call it as a booked case. Right? And she should take regular iron folic acid and she should get immunized with TT.
TT, yes.
So what is it? Can you tell me what are the minimum checkups to call it as a booked case?
A minimum checkup number is 4 visits, ma'am. Once in the three visits.
Yeah.
One visit should be in the first and or second trimester.
Yeah.
From 28 until 28
trimester.
In the third trimester. For every 15 days, she should
get in the third trimester. It should be 2 checkups.
2 checkups. Okay.
I'm not telling about the ideal checkups. I'm telling about the booked case where it requires only 3 checkups. Right now, you could find the difference.
Yes.
So that is how you call it as a booked case. Next, you call it as immunized. So what do you mean by immunized?
When she's getting her regular B12 supplementation and iron supplementation, and she has gotten her TT dose. Both are TT doses.
Yeah, that is an immunized pregnancy. Yes. Next, you can go to the next slide. Any doubts till now? Nothing. You're clear, right?
Yes, ma'am.
Yeah.
The chief complaint: the patient has come for a scheduled antenatal checkup at 30 weeks and 6 days of gestation. This is her 7th visit. Okay. History of present illness: there are no specific complaints at this time.
Right.
Now coming to the history of present pregnancy, first trimester, 0 to 12 completed weeks of gestation. Okay. Pregnancy was tested at 40 days of amenorrhea by urine pregnancy test at home and confirmed by ultrasound scan at hospital.
What is the scan? You wrote it, right? Okay. Next.
Yes. There is no history of nausea and vomiting in pregnancy. There is no history of hyperemesis gravidarum. There is no history of fever with rash. No history of frequency of micturition. Okay. Folic acid supplementation was taken by the patient. Okay. Dating scan was done at 7 weeks of gestation. Nuchal translucency scan was done at 14 weeks of gestation, both of which were normal.
Okay, wait here. So now she has tested her urine pregnancy test and at 40, yes, right? So
yes,
you have asked her about hyperemesis gravidarum. So what is this excess vomiting? What is the cause of this hyperemesis gravidarum?
So the cause of hyperemesis gravidarum are generally if there's a strong familial history of excessive vomitings, the patient is more
predominant hormone which is responsible for this.
HCG, ma'am, human chorionic gonadotropin.
So is it present throughout pregnancy, this HCG?
Yes, ma'am.
Then why this and hyperemesis only till 12 weeks? Why is it common in the first 12 weeks?
Usually there is a peak of HCG at the 12th week of gestation, ma'am.
So it is the main cause is because of the changes in the beta HCG level that is responsible. So this fluctuations in the beta HCG, what exactly, right? So during in the early pregnancy, the beta HCG will tend to rise with each and every week. So and after few weeks, after 10 to 12 weeks, it becomes a plateau or a peak, right? And after that, the HCG levels will be stable, right? So it is because of these fluctuations in the beta HCG that will act upon the vomiting zone. What is the vomiting zone?
In the hypothalamus.
What is it called? So it is a chemo trigger zone, right?
CTZ,
CTZ. So this beta HCG will act on this CTZ and it will cause this fluctuations. What exactly? And after achieving a plateau level, the CTZ will get a kind of tolerance to beta HCG. That's why this hyperemesis is very much common in the first trimester, right? Next, you have asked about fever with rash. How is it relevant?
Fever with rash is important because diseases like measles, chickenpox, and rubella. The fever with rash is characteristic of these 3 diseases, ma'am.
Yeah. So why are you worried about those diseases?
Because these have high teratogenic effect on the baby.
They usually cause congenital malformation, the fetus, right? And they also cause IUGR, that is early onset. Intrauterine growth restriction.
Yes,
right? So that's why you are worried about fever with rash. Next, what about frequency of micturition? Is it common in first trimester?
Yes, ma'am.
Why?
Because the uterus is still in an anteverted position, so it is exerting pressure on the urinary bladder.
Pelvic organ.
Uterus is still a pelvic organ in the first
trimester. A pelvic organ, right? And this pelvic uterus will compress upon the urinary bladder, which is present anterior to the uterus, right? That is the cause. which is very common, frequency of micturition. It is not always pathological. It is physiological also.
Yes.
Right? Next, you have written about folic acid supplementation. So what is the dose you would like to give? Okay. So for suppose, if it is a regular supplementation, it is 0.5 milligrams or 500 micrograms, right? For suppose, if she had any history of previous pregnancies with neural tube defects, baby had neural tube defects, then the dose should be 5 mg, that is 5 milligrams.
Yes.
Got it? So if it is a prophylactic dose for everyone, it is 0.5 mg. And if she had any history of NTDs, it should be 5 mg. Right? You got the difference.
Yes, ma'am.
Right. Next. Dating scan. You have written as dating scan. So what is the significance of this early trimester or first scan?
Dating scan is an ultrasound scan that is used to check if the fetal growth is normal or not.
So I want to know what is the significance of a first trimester ultrasound.
Developmental delays can be detected.
Can't really, at that very early gestational age, you can't really detect the developmental delays. First
If
of
there's
all,
any anomalies.
pregnancy, right?
Yes.
Because you can't see anything on the abdomen, right?
Yes, ma'am.
So first of all, the scan will confirm your pregnancy. And it will tell you whether the pregnancy is in the uterus or outside the uterus.
Yes.
Right? What is the pregnancy outside uterus called?
Ectopic pregnancy.
Ectopic. So you'll know whether the pregnancy is intrauterine or ectopic. Next, you will know the number of fetuses, whether it is a single pregnancy or a twin pregnancy. Right? And also, you will know the dating. So why it is called a dating scan?
It will help us to know the period of gestation.
It's the pregnancy, because for suppose if the woman is not sure of her dates, she doesn't know her LMP, and her cycles are so irregular, where you can't rely upon her LMP, then the main thing there you'll rely is the dating scan, right? It will date you the pregnancy, depending upon the crown rump length, right? We'll measure the CRL of the fetus and we'll date the pregnancy.
Yes.
Right? That
Yes,
is it. So you have written NT. Shall I ask
no.
about NT? What is NT?
In nuchal translucency test.
So what do you look for in the nuchal translucency?
It will tell us about the neck thickness and also the amniotic fluid. It will tell us about the liquor amount.
Mainly, it is not the liquor. It will tell us about the nuchal translucency, neck thickness, right?
Yes,
and it is mainly to exclude the, what do you want to exclude with that NT?
Anomalies, ma'am. Any anomalies? Down syndrome.
Yeah, it is chromosomal anomalies. You want to exclude the chromosomal anomalies, you will get an NT scan done.
Yes.
Yes. You can go to the next slide. Any doubts till now?
No.
No. Yeah, go.
In the second trimester, that is from the 13th week of gestation to 28 completed weeks of gestation, her number of antenatal visits were 4. The time when quickening movements were felt is the 19th week of gestation.
What is quickening?
Quickening is when, no problem. When the mother can perceive the fetal movements for the first time, it is known as quickening movements.
So what is the normal quickening in a primary and a multi?
In a primary gravida, 18 to 20 weeks of gestation is the ideal time. In a multi gravida, 16 to 18 weeks of gestation.
Why your quickening is relevant?
Again, quickening will also help us in knowing the period of gestation.
Yeah, how this is possible with quickening?
Ma'am?
How will you calculate the EDD basing on quickening?
19 weeks of gestation. So we'll go back 19 weeks, ma'am.
So we'll add, if she's a priming, we'll add the date of quickening plus 20 weeks. Because in priming, it is usually at 20 weeks quickening. So 20 plus 20 is 40 weeks, right? Yes, and if it's a multi, it is around 18 weeks, right? 18. So we'll add 22 weeks. So by the date of quickening, we can add 20 weeks in a case of priming and 22 weeks in a case of multi to know her expected date of delivery date. Right. Next.
Tetanus toxin vaccinations were given. 2 doses were administered. One in the 15th week of gestation and the other at the 19th week of gestation. Iron and calcium supplementation were being taken by the patient. There is no history of bleeding per vaginum, no history of leaking per vaginum. Screening test for gestational diabetes mellitus was done. The results were normal. Scan for fetal anomalies was also done, that is TIFA. targeted imaging for fetal anomalies, which was done at 21 weeks of gestation, revealing normal results.
So in the first trimester, you have missed some important points. What are those? You haven't mentioned about radiation exposure. You haven't mentioned about any teratogenic
Drug intake.
because they are also important, right? So you haven't mentioned about any bleeding,
Yes, ma'am.
bleeding per vaginum in the first trimester. You have mentioned here, but in the first trimester, it is important. How?
Implantation bleeding can be seen in the first
You
trimester.
know, what is bleeding? Bleeding per vaginum in the first trimester is not always pathological.
Normal. Yes,
right?
it is physiological.
Physiological also. What is called an implantation bleeding? What is an implantation bleeding?
Implantation bleeding is when the developing fetus gets implanted on the posterior wall of the uterus. There is mild spotting seen, which is called implantation bleeding. This can sometimes be mistaken for last menstrual period also.
Yeah. So it is usually very minimal, right? And it is altered color, minimal spotting, right? And it is usually self-limiting.
Yes, ma'am.
Upside by itself. What are the pathological causes of first trimester bleeding?
Abortions, ma'am.
Abortion. Yeah.
If there is any trauma to the cervix.
Okay. Trauma, which is very rare, right? Next.
Yes.
Ectopic pregnancy. Yes, ectopic pregnancy can also cause bleeding per vaginum. Next. Molar pregnancy. Have you heard about molar pregnancy?
I don't know much about it.
So even that can also cause bleeding PV, which are pathological causes of bleeding PV in the first trimester.
First trimester.
Right? So again, drugs and radiation. You have mentioned, you didn't mention it, but you have to write it. Right? So what is the radiation cutoff at which you expect anomalies?
Anything more than 20.
More than 5 rads.
5 rads.
More than or equal to 5 rads. Right? But the basic X-ray which we take, it could be either chest X-ray or abdomen X-ray, whatever it could be. The radiation is below 1 rad. Right? So if at all anyone comes to you like saying that I've been exposed to X-ray, I have taken a chest X-ray, is it better to continue pregnancy or shall I have to terminate? You better tell them that you continue the pregnancy because the radiation is very minimal, only less than 1 rad. And the anomalous is usually more than or equal to 5 rads. Right? Next. And drugs is also important. Next. Second trimester, you have mentioned about TT vaccination, right? So what is the schedule for TT vaccination?
Anytime from 16th to 18th week of gestation should be the first dose. And the second dose should be?
Not necessary. So ideally, it should be as soon as the woman get registered. Right? You can get it done. Even if it is first visit, you can get it done. As soon as she gets registered. Right? And the second dose will be 1 month after the first dose.
4 weeks from the first
dose. For
our
convenience, we are giving it at around 16 to 20 weeks. That's it. But ideally, what the protocol says is that she can get it done as soon as she got registered. Right? And the doses are 2 doses, right? First, suppose she's pregnant for the second time and her baby is less than 3 years. Do you want to still give 2 doses?
No, ma'am. She should be given a booster shot.
She should be given only 1 dose. And now the routine TT is not given nowadays. It is replaced by TD.
TDAP.
Yes. TD. That's not TDAP. It is TD. TD is government. Contains tetanus and diphtheria. But the recent protocol is TDAP. Means it is tetanus, diphtheria, and pertussis. That can be given as a single dose at 28 weeks. Right? But according to government setup, it is TD, not TT. Right? Next. Iron and calcium. So what is the ideal amount of iron you want to supplement? How much?
Doses.
So this is important, right? So according to WHO, right, it should be 60 milligrams of elemental iron and 0.5 milligrams of folic acid, right? That should be given throughout pregnancy and also 180 days after delivery. That is the protocol, right?
Yes.
That is minimum. Next, calcium. Calcium is 1 gram per day. Right? Next. So now you have wrote about the symptoms suggestive of preeclampsia. So what are the symptoms you asked for?
Okay. So if there is excessive weight gain, if there is blurring of vision,
Okay.
If there was headache, pedal edema.
Pedal edema, but now it is excluded from the criteria. Okay. Next.
And
Epigastric pain, headache,
epigastric pain, yes.
decreased urine output. Right? So these are the
Yes,
symptoms related to preeclampsia.
Preeclampsia. Preeclampsia is when if a mother who has come for her checkup has a blood pressure of more than 140, equal to or more than 140 by 60 mmHg
90.
over at least, 90 mmHg on at least 2 recordings which are 6 hours apart. Yes.
After 20 weeks.
20 weeks of gestation.
You have to mention the gestational age, right?
Yes.
If it is before 20 weeks, we call it as chronic hypertension. So you have to mention the cutoff gestational age.
Yes.
Next, screening test for GDM you have told. What is a screening test?
Oral glucose tolerance test.
So it is OGTT. So how much you will give?
75 grams of glucose should be mixed with 300 ml of water. Should be ingested within 5 to 10 minutes.
Okay.
And the mother's blood glucose level should be tested every 1 hour.
Okay.
So the normal levels are...
So first of all, you have to measure the fasting glucose also, right?
Yes, ma'am.
After that, you need to check for 2 hours.
OGTT.
1 hour for 2 hours, right? What are the cutoff values?
OGTT, the cutoff is 140 to 160 grams per DL is the normal. 140 to 145 to 150.
No. So if it is OGTT, it should be fasting more than 92.
Yes.
First hour more than 180. Second hour more than 153. This is important. This is important for your exam. So 92, 180 and 153. First, suppose if the woman is not in fasting stage, do you want to send her back and tell her to come again? No need. No need. So nowadays there is a criteria which is a DIPSI criteria, right? DIPSI, D-I-P-S-I, DIPSI criteria. This is followed in India, where you will give 75 grams of glucose and we'll check the second hour value of blood glucose. Right? It should be less than 140.
Oh, yes.
It's DIPSI, where you will take only a single value, irrespective of the last meal and irrespective of the fasting status of the patient. Right?
Yes,
that is DIPSI. Okay. Next, you have, and what is the ideal gestational age at which you will do this GDM screening?
Every time the mother has come for an antenatal checkup, we should check.
As the India is a high endemic for diabetes and all, so we'll do it at the registration, at the booking visit, GTT. And after that, if the booking visit GTT is normal, we'll repeat it at 24 to 28 weeks. Got it? Two times. Not necessary at every time. Only 2 times. Right? That's it. Next. So you have talked about TIFA scan. So when is the normal TIFA scan done?
At any time between 18 to 22 weeks of gestation, TIFA should be done.
It's where you will know the anomalies of the fetus, right?
Yes.
Next slide.
The third trimester, that is 29 weeks of gestation to labor. The number of antenatal visits have been 2. The mother has been perceiving normal fetal movements. Again, there is iron and calcium supplementation is being taken. No history suggestive of preeclampsia, no history of bleeding per vaginum, no history of leaking per vaginum, no history of pain in abdomen. There is mild pedal edema. All the routine antenatal investigations were done and found to be normal.
So what did you mention about bleeding per vaginum in the third trimester? So what could be the causes of bleeding per vaginum in the third trimester?
Generally, bleeding per vaginum is suggestive of abortion.
Abortion, but now she's in third trimester where your abortion cutoff is over. It is before 24 weeks, right? Abortion.
Okay.
Now she's in the third trimester after 28 weeks. First, suppose she had any bleeding PV. What is the thing you will suspect? And what is that called? Yeah, it could be labor. Very good.
Yes.
Could be a preterm labor where she has.
Placenta.
Yeah. That what is that
placenta
called?
previa.
Placenta previa. Yeah. If at all the placenta is implanted in the lower segment, there is every chance that after 28 weeks, the lower segment will form.
Yes, ma'am.
And as and when the uterus expands, the placenta is still there and the bed plates, right? That is placenta previa. What is the other? Abruptio placenta.
Placenta. Abruption placenta is when the placenta
There is no-
comes out first and then
Yeah,
baby
there is
is
a
delivered.
premature separation of placenta.
Placenta.
Right?
Yes.
So any bleeding after 28 weeks, we'll call it as an antepartum hemorrhage.
Hemorrhage.
Right? And the two most common causes are the placenta previa and
abruption
abruption.
placenta.
Right?
Yes.
Or as you said, it could be a labor pain also, having show. Right?
Okay.
Next.
Yes.
So you have mentioned about pedal edema, mild pedal edema. So what are the causes of pedal edema in pregnancy?
Pedal edema is a physiological phenomena that is seen during pregnancy.
Okay.
Causes are because of increased hemodilution. So there is an increased volume of fluid in the body, which causes pedal edema. There is also a state of hypoalbuminemia, which decreased by 30%.
That is all pathological causes. Most physiological cause of pedal edema is because of the uterus, which is compressing on the inferior vena cava.
Inferior vena cava.
That is the cause of physiological edema, right? So as it compresses,
femoral venous pressure is elevated.
circulation is obliterated. So
Yes.
what are the pathological causes of pedal edema?
If there is a problem with the liver functions, albumin levels is decreased, causes edema. Again, preeclampsia
Because there will be
can be seen.
proteinuria.
Proteinuria, yes.
Or it could be any anemia.
Yes.
Anemia also, there will be hypoproteinemia. Right? And also it could be congestive cardiac failures. Right? These are all the pathological causes of edema. How will you differentiate between a physiological and a pathological edema?
Generally, physiological edema will subside after 6 hours of rest.
After 12 hours.
12 hours of rest, but pathological cannot be
very
reduced. Next slide. No?
Next slide.
The menstrual history. So the age at menarche for the mother is 14 years. She has regular cycles. Past cycles are regular 28-day cycles with flow lasting for 4 days with normal quantity with occasional spasmodic dysmenorrhea, and there are no clots during her menses. Her last menstrual period was on...
No need to mention here again. Okay.
Yes. Marital history, the patient has been married for the past 11 months and it is a non-consanguineous marriage.
About the consanguinity, how is it relevant?
Generally, in consanguineous marriages, there is a high chances of anomalies in the baby. Mental retardation can be seen in the baby.
Okay.
Contraceptive history, there is no history of using any contraceptive methods. Can I go to the next slide? Now, past history, that is both medical and surgical history. No history of diabetes mellitus, hypertension, cerebrovascular accident, coronary artery disease, bronchial asthma, epilepsy, and tuberculosis. There is no history of surgical procedures and blood transfusions.
So how is it relevant, past history?
Past history will give surgical procedures and blood transfusion will be helpful during labor. During delivery. The remaining, because of the medications that we use during pregnancy, some drugs that are used for these conditions have teratogenic effects on the baby. Like epilepsy, phenytoin is teratogenic. Some TB, drugs for TB are also...
Characterize the pregnancy as low risk or high risk?
Low risk, high risk. Okay, yes.
And also you can review the medications, what all she's using.
Yes, right.
Next, personal history.
Personal history, the patient takes a mixed diet. She has a good appetite. Her sleep cycle is sound. Both her bowel and bladder movements are normal and she has no habits.
What habits you expect? Or did you ask?
We asked one because generally in mothers, in rural areas, they're used to chewing tobacco. Some people in some rural areas are also used to alcohol.
Not only rural.
These have a deleterious effect on the fetus because it causes abortions. Intrauterine growth restriction can also be seen. Smoking has teratogenic effects on the fetus.
Next.
Family history, the patient has a paternal history of hypertension And there are no history of congenital abnormalities, twinning, and diabetes mellitus. Can I go to the next slide? Case summary. So this is Mrs. KL, age 24 years, in her first pregnancy, has come for scheduled antenatal visit at 30 weeks and 6 days of gestation. She's a booked case and has regular antenatal supervision. She's immunized and has received iron and calcium supplementation throughout. All 3 trimesters of her pregnancy have been uneventful till date.
Examination.
Yes, ma'am. General physical examination. The patient was conscious, coherent, cooperative, and oriented to place, time, and person. She is moderately built and well nourished. Her height is 154 centimeters. Her weight is 65 kgs. That is, and her pre-pregnancy weight was 55 kgs, indicating a 10. Sorry, ma'am.
A BMI.
Her BMI is 27.4 kgs per meter square.
Is it ideal or is it overweight or obese? What is it?
It is healthy, ma'am. It is normal.
No. So if it is, what is ideal BMI is between 18.5 to 24.9. That is ideal, right?
Yes, ma'am.
After 25 till 30, it is overweight, right? After 30, it is obese. Now she comes in
Ma'am,
the category of, as the
overweight.
BMI is 27, she comes under overweight, not ideal, right?
Yes,
So
ma'am.
why is this BMI important?
BMI will give us an idea about if she is underweight, normal, or overweight.
Yeah. What will you infer? And like, what are the complications you expect in a low BMI patient or in a high BMI?
In a low BMI patient, there are chances of anemia, ma'am, malnutrition,
Malnutrition, IUGR also,
IUGR, yes,
right?
ma'am.
While for suppose if she is overweight or obese, there is more
Gen-
chance of preeclampsia,
GVM.
diabetes, whatever, right?
Yes, ma'am. Yes, ma'am.
Next.
Pallor, there is pallor can be seen.
What are the sites where you look for pallor?
Lower palpebral conjunctiva, her palms, tongue,
Dorsum of the tongue,
that's dorsum of the tongue, and palms, ma'am.
palms, nail beds.
And nail beds, yes, ma'am. Icterus, cyanosis, clubbing, and koilonychia and lymphadenopathy were absent. Pedal edema could be seen.
The sites where you look for icterus.
Icterus should be seen in the upper palpebral conjunctiva, the dorsum of the tongue.
Under surface of the tongue.
Under surface of the tongue.
This is anemia. This is under surface. Okay.
Yes, ma'am.
And so also you can look at the soles and palms also.
Yes.
Right? Icterus. Cyanosis, as you already know, at the nail beds. Right?
Nail beds, yes.
Clubbing. No, sorry. Clubbing is at the nail beds and cyanosis is at the tip of the
Tip
nose.
of the nose.
Earlobes. Right?
Peripheral parts.
Peripheral parts. Right. Next. Lymphadenopathy. And where do you elicit pedal edema?
Feet. We have to look at the medial malleolus, check if there is pitting or not.
Next, what
For
else?
15 seconds.
What else? What are the other sides?
Medial malleolus. The foot, the dorsum
Dorsum of the foot, yes.
Yes.
What else?
That's it.
Shin, tibial shin of tibia, right? And also you can elicit on the lower abdomen, vulva also, right? Because, and also sacrum.
Sacrum in bedridden
They're all the
patients.
dependent portions where
Yes.
edema is very common, right? Next
Okay.
slide.
Vital data of the patient. The patient is afebrile. Her pulse is 85 beats per minute with normal rhythm and character, but bounding in volume. All peripheral pulses were equally felt. Respiratory rate was 22 breaths per minute, thoraco-abdominal in nature. Her BP was 120 by 68 mmHg, measured in the right upper limb in sitting position.
So what is the ideal position of measuring the blood pressure?
Either sitting or, and we should be at the level of the patient, or when the patient is lying down.
In the left lateral position. Why not in the dorsal position?
Not sure.
Because the uterus will be compressing on the inferior vena cava.
Inferior vena cava.
Right? So there is
Yes.
every chance of hypotension in the supine position, which we'll call it as a supine hypotension syndrome.
Hypotension.
Right? So that's why the ideal position should be either best position is sitting, otherwise it is in the left lateral
Left
position.
lateral
It's not
position.
able to sit properly.
Okay.
Right? And
Yes.
what Kortkov sounds you have? Either it is
Sorry?
Kortkov sounds. What are the sounds?
The whooshing sound that we hear when we are
And what is the sound where you will measure the diastolic? Is it muffling or is it disappearance of sound?
disappearance of sound.
Yeah, disappearance is what is 4. Kortkov 4 is 5, sorry. Right? If it is not disappearing, then you can go for muffling. It is 4.
Okay.
Right? Ideally is disappearance. Right? Next.
Systemic examination, both S1 and S2 were heard. There are no murmurs. Respiratory system, normal vesicular breath sounds are heard without any basal crepitations or abnormal sounds. Obstetric examination. So the patient was examined in supine position with her legs semi-flexed to relax the abdominal muscles, except during the measurement of sympathio-fundal height. Inspection, the abdomen is uniformly distended and globular.
First of all, tell me the prerequisites for examination, for examining the patient.
We should take the consent of the patient. We should explain to the patient how we're going to examine her. We should make sure that the patient is in a comfortable position.
Major one more important thing, which you forgot.
The site of examination should be clear.
You should tell her to go and empty her bladder.
Empty her bladder.
That is the very much important point, which we expect, right? Next.
Yes. Inspection. On inspection, the abdomen is uniformly distended and globular in shape. Both linea nigra and stria gravidarum can be seen. In the diagram, the green line is the linea nigra. Both the red lines are indicating the stria gravidarum. Flank fullness cannot be seen. Umbilicus is normal. The hernial orifices are normal. No scars or sinuses are present.
What is linea nigra?
Linea nigra is a straight line that is present generally during pregnancy, cause of which is unknown. Some hormonal.
It is known.
Progesterone level elevation.
Of the estrogen and progesterone, which will raise the MSH, that is melanocyte stimulating hormone. Right? That is the cause of this linea nigra. What is the cause of stria gravidarum?
Stria gravidarum, also called stretch marks, are seen because of the stretching of skin over the abdomen.
Collagen. Because of collagen fibers. Right?
Yes.
Stria gravidarum. And you have told that there is no flank fullness. So how did you elicit the flank fullness in the patient?
When we're examining for flank fullness, when the patient is sitting, we have to look at the patient from behind. If we see any lateral, anything lateral, then flank fullness can be seen. If there is no lateral.
So the flank fullness should be elicited in the sitting position and we stand behind the patient.
Yes.
Right? Yeah.
Yes. Next slide.
Normal. Okay. Next.
So after inspection, we'll do palpation. The fundal height was palpated with the ulnar border of left hand. Resistance could be felt above the umbilicus. When measured, this was 31 centimeters.
Fundal height? How will you measure a fundal height? Or how will you elicit fundal height?
Where we feel resistance, we mark a point, ma'am, and ask the patient to stretch her legs. From the pubic symphysis, we measure up till the point that we have marked.
So which is where and which part of the tape you would like to keep towards you? Is it an inches part or the centimeters part?
Towards us, we put the inches part, ma'am, and when we have to measure, we turn it and look at it in centimeters.
You want to do so?
To get accurate measure.
Why can't it be accurate with centimeters towards you?
Stretch is
no. To avoid bias, right? So you have to keep the inches towards you and the centimeters towards the patient. So that after measuring, you have to turn the tape. So otherwise, what you will do, if she's 32 centimeters or 32 weeks, you tend to keep the tape till 32. Right?
Oh, okay. Yes.
To avoid the inter-observer bias, right? You have to blindfold yourself. So how will you blindfold yourself? You'll keep the tape.
By not looking.
Right? You should not look at the tape.
Yes.
Right? And this is the only measurement which is measured with the legs extended.
Legs in the extended position.
Meaning all should be in the legs semi-flexed.
Yeah.
Right? So what is the significance of this symphysiofundal height?
Symphysiofundal height will also tell us if the period of gestation and the growth of the fetus are in correlation or not.
So how is it like?
Okay, until 12 weeks, until the first trimester, the uterus is still a pelvic organ. So until 12 weeks, the uterus is at the level of pubic symphysis. And at the level of umbilicus, it is 24 weeks, ma'am. So the region in between is divided into 12 weeks, 18 weeks, 12 weeks, 16 weeks, 18 weeks, and 24 weeks.
Okay.
And from the umbilicus to the xiphisternum, it is again divided into 3 zones. 24, 28, 32, and 36.
But what is the importance of symphysiofundal height is, so the symphysiofundal height in centimeters is equal to your period of gestation.
Period of gestation, yes.
That is important, right? So
Yes.
between 18 weeks till 32 weeks, the symphysiofundal height should correspond
Is
to your
equal to
gestation.
period of gestation, yes.
Suppose there is any lag. If the lag is more than 2 centimeters, then there is something abnormal. Means the baby is not growing properly, or there is no adequate liquor. That means your symphysiofundal height is not corresponding.
Yes,
right? So what are the conditions where the fundal height will not correspond, is less than your period of gestational age? Name the conditions.
Fundal height is less than period of gestation. Conditions in which there is less amniotic fluid, like oligohydramnios, intrauterine growth restriction.
Yeah. First and most common is wrong dates.
Yes.
Wrong dates. First, tell the physiological thing, right? So wrong dates, or it could be any IUGR, as you told. It could be any oligohydramnios, or it could be an IUD, intrauterine death, or it could be a transverse line. Right? Baby is transverse.
Yes.
So fundal height will be less. Right? So name the conditions where your fundal height is more than the period of gestational age.
Polyhydramnios.
Polyhydramnios. What else?
Wrong
dates again.
Again, wrong dates. Yes.
Yeah. What else?
Twins.
You have told IUGR. Why can't you tell it big baby?
Big baby. Okay. Yes.
Yeah. Twins. You're right. Twins. Right. What else? Any fibroid in the uterus? Ovarian cysts? Yeah.
Yes,
so these are the conditions where your fundal height will be
more than the period of gestation.
It's important. This will be definitely asked in the exam if it is a routine antenatal case, right? Next, what next? Continue.
Now coming to palpations, we have now grips, also called Leopold's maneuvers. There are 4 grips. The first grip is the fundal grip, where we palpate the fundus of the uterus. We face the patient and we palpate for the fundus. Here, a large, broad, non-palatable mass was felt, which is suggestive of buttocks. Lateral grip, the second grip, that is lateral grip. One hand is used to stabilize one side of the uterus and the other is used for palpation. Here, a smooth, curved, uniform resistance was felt on the right side. Which was suggestive of the fetal spine. And small, knobby, irregular parts were felt on the left side, which was suggestive of limb buds. Can I go to the next slide now? Next. Okay. Now, the first pelvic grip or the third Leopold's maneuver or Pollock's first grip. Here, a smooth, hard glob, ulnar border of the right hand is placed on the pubic symphysis, and the uterus is palpated with the thumb and forefingers. A smooth, hard, globular, palatable mass was felt, which was suggestive of fetal head. The presenting part was freely palatable, which indicated that the baby is not the mother is not in labor.
It's not engaged, not in labor.
Engaged. Yes. Second pelvic grip or Pollock's second grip, the fingers converged when placed parallel to the inguinal ligament, which indicated that the head is not engaged.
Is there any difference where you are eliciting till now, the fundal grip or lateral grip or the first pelvic grip to the second pelvic grip? Is there any difference in your position?
Okay, in the second pelvic grip, we face the patient. We face away from the patient. We face the legs of the patient.
Foot, right?
Yes, ma'am.
While the other grips, like fundal or lateral or the first pelvic grip, will look at the patient's feet.
Yes, ma'am.
And what is your inference with the second pelvic rib? Why do you want to do, what are the things you will get in
The second pelvic rib, it confirms the first pelvic
confirms
rib.
your
Ma'am.
first pelvic rib. Will tell you which part it is. It will tell you the presentation, right?
Yes.
It also tell you whether the head is engaged and or not.
Engaged or not.
What is the third important point which it will tell?
Generally, it is done during labor. Ma'am.
No, not exactly. Not.
Um,
So it will tell you the attitude of the fetus. Attitude.
meaning presentation.
No, attitude means whether the baby is a well-flexed baby or a deflexed head. It is a well-flexed or a deflexed head, right? So how will you know a well-flexed head? Well-flexed means the head is flexed. Imagine the baby is upside down and the head is flexed. So on the side of back, which is the prominent part, is it occiput or sinciput? On the side of back, occiput, right? And the other one, the other pole, opposite pole is a sinciput, right? But suppose if the baby is well flexed, it is flexed, it is deflexed, it is extended. So you imagine this is the baby's head. This is occiput, this is sinciput, right? If it is a well flexed head, baby is like this in the mother's womb, upside down, right? So it is well flexed, means the occiput will be at a lower level when compared to the sinciput. If it is deflexed, occiput and sinciput will come at the same level.
Same level.
Extended. Sinciput will be at a lower level when compared to occiput, right?
Yes.
This is called attitude of the fetus. We'll know whether it is a well-flexed head, deflexed head,
deflexed or
extended head.
Extended.
So these are the three things. This is called attitude, right?
Okay.
So the second pelvic will not only tell us the presentation and engagement, will also tell us the attitude of the fetus.
Yes.
Right? Next.
Okay. Auscultation, fetal heart sounds were heard along the right spino-umbilical line. They were 142 per minute, regular and rhythmic. Can I play the video?
Yeah.
Baby heart.
Usually it is heard in the spino-umbilical line, right?
Yes, ma'am.
Either if it is right in the right occipital position, it is right side. If it is left occipital, then it is left side.
Left spine.
Yeah.
Yes. Diagnosis. The patient is a 24-year-old booked primigravida at 30 weeks and 6 days of gestation, not in labor, is in her normal pregnancy.
So how do you want to follow her? So what are the investigations you would like to order in her booking visit, first visit?
The regular investigations that we do are complete blood picture, ma'am. Liver function tests and renal function tests. During booking, we also have to do the OGTT, screening test for diabetes. We have to look for viral markers.
Markers, yes.
We have to do a complete urine examination.
Okay.
That's
one thing. Thyroid.
Sorry, thyroid.
Okay, and also a dating scan. Right?
Yes.
So what are the what are the other tests? Like as you go on, tell me according to the trimester wise. In the second trimester, you have already told about TIFA scan and also the GTT at 24 to 28. What next?
For
5 minutes.
TIFA, generally in the growth scan should be done in the third trimester.
Do a growth scan.
Ma'am? In the third trimester, ma'am.
So it is ideally at 32 weeks, right? 32 and also 36 weeks.
Yes, ma'am.
And when do you want to recheck her hemoglobin?
Generally, every time she comes to get a checkup done, blood tests are done.
Need not be at every checkup. Hemoglobin need not be at every checkup at 28 weeks and 36 weeks. That will be fine, right? Okay. So now your case is a normal risk. It is not a high risk case. So how do you want to follow her? So
make sure she is schedule her for a vaginal delivery.
That you can't tell it right now, right? She's just 30 weeks and you can't tell her whether she is fit for normal delivery or not. You can schedule her checkups, that's all, right? You tell her that as she's 30 weeks, you tell her to come every 15 days, right? And as she's a low risk case, and if she's awaiting for a normal delivery, you can tell her to wait till her EDD, that is expected date of delivery. Yeah. So how many percentage of women will deliver on the date of EDD?
4% of women only deliver.
Yeah, 4%. Right?
Either 2 weeks earlier or 1 week later, the estimated delivery date.
That's right. Okay. What else? Any doubts you have?
Mhm.
And any questions from the audience? Okay. So
Thank
it's
you.
a very good presentation by Devika. It's a
Thank you.
good job. You have answered almost all the questions, right? Yeah.
Okay.
And
Thank
thank
you, ma'am.
you for giving me this opportunity, right? Thank you. చెప్పండి సార్ ఎనీ క్వరీస్ అని అడిగాను.
Thank you. Thank you. Any questions from anyone? Sir, good evening, sir.
Good evening, sir. Good evening. Two questions are going to get here.
Sir, gynec just passed, sir.
Other problem.
At that time, we did not have these opportunities and we were not aware how to read, what to do, nothing. Only we were based on what senior used to tell. Senior told you read Mudaliyar and some important questions from Falcon. That's it. That's how we passed. Just before the exam date, one of my senior, I still remember, Bhavani Shankar. He brought that pelvis and he explained me normal delivery. I don't know how I passed also, sir, by
Somehow we did not have intrapartum complications while examination. What are the medical complications expect, Devika? Medical complications in pregnancy.
Postpartum hemorrhage can be seen.
Okay.
Bleeding disorder. If the mother has any bleeding disorders, excessive bleeding can be seen, sir.
Yeah.
So anyone interested to ask any questions, madam is a gold medalist and you can clarify your doubts. This is an opportunity for you to interact with the faculty. So if you don't interact and sit like this, there is no point in conducting these programs. So first step, you have done good coming here and joining the session. Second step is interact, come out of that fear and be bold. That is the idea. That is what will make you apart from other students. So already you have come here, that's a good thing. Start, ask anything under the earth you can ask her. If she is having the answer, she will tell you. Otherwise, you can go and refer back. Okay. So you have 5 minutes now. Already we are beyond our scheduled time. So 5 minutes for discussion. Anyone willing to ask any question? Yes. Otherwise, Dr. Naresh, you can take over and we can end this session.
Yeah. Dr. Sneha, Megha, Gopi Chandana, Divija, Bhargavi, please switch on your mics and probably you can discuss here. Arav Reddy, Kirti Singh. Sagar Unnava? Sagar?
Sir, no.
Good evening, namaste. That was a very nice grilling session, madam. Nice grilling.
Thank you, sir. Thank you.
You are an RMC, madam. Rangarail unnara meeru? Are you an RMC, madam? Rangarail unnara?
Rangarai only, UG and PG, everything Rangarai.
Oh, okay. Satyasrinivas మీకు తెలిసే ఉంటాడు కదా, డాక్టర్ సత్యశ్రీనివాస్, మెడిసిన్.
Yes, sir. Yes, sir.
He was my first PG, Satya.
Okay. Yes, sir.
Okay, I think, Sagar, shall we close the session then?
Yeah, sir. Yeah, sir.
Okay, Sagar, then, any students want to talk or present anything or any questions? I think that was a very exhaustive presentation, and it really speaks a lot about Madam's gold medal. She has been extremely thorough, probably a long time since even I have seen such a beautiful line of questioning and bringing the best out of the student. Thank you, ma'am. I think I can now understand why Harsha is so perfect in everything. He has a very good, very good teacher at the house. So with this, we will end the session with the Omkar Mantram. Devika, you can end the session, please.
Thank you, sir.
Devika.
Yes, sir.
Sir, I'm-
Omkaram.
Thank you so much.
Can I start the Omkaram?
Yes, ma'am. Yes.
नत्वहं कामये राज्यं न स्वर्गं न पुनर्भवं कामये दुःखतप्तानां प्राणिनामाश्रिताशनम् ॐ ॐ ॐ Thank you.
Thank you, sir. Thank you so much.
Namaste.
you, ma'am.
Sagar, I'm logging off.
Sir?
Yeah, but, no, బయటికి వెళ్ళిపోతున్నాను ఇంకా.
Okay, sir. Okay, sir.